There are 3 stages to labor, and then a final stage which is called recovery. Some people call it stage 4. Within the first stage of labor, there are 3 different phases. The latent phase is when contractions become more coordinated and the cervix reaches 4 centimeters dilation. The latent phase can last as long as 12 hours for women who have given birth previously, which is called multiparous, and as long as 20 hours for women who have never given birth before, which is nulliparous. The second phase, or active phase, occurring in stage 1, is when the cervix dilates to approximately 8 to 9 centimeters, and it is the phase of the most rapid cervical dilation. This lasts about 5 hours in nulliparous women and about 2 hours in multiparous women. Then there's the deceleration phase, which is also known as the transition, and the cervix reaches complete dilation here, and the presenting part of the fetus, which is hopefully the head, descends into the mid-pelvis. Now moving on to the second stage of labor, this is the time between full cervical dilation and the delivery of the fetus to the extrauterine world. This can last approximately 2 hours in nulliparous women and about 1 hour for multiparous women. Finally, the third stage of labor is characterized by the delivery of the placenta, and this stage can take up to about 30 minutes. Then in the recovery stage, this is where there is shrinking of the uterus. Fetal heart rate monitoring has become a standard of care in the United States during the labor and delivery process. Trends in the fetal heart rate monitor are used to estimate a fetus's tolerance of the labor process and to assist the delivery team in making decisions on the method and speed of delivery. Baseline heart rate, beat-to-beat variability, and chronic variability, such as accelerations and decelerations, are monitored throughout labor and delivery. In order to monitor fetal heart rates, we first need to determine the baseline. We do this by observing the tracing for 10 minutes. The baseline is a range of heart rates in which the fetus's heart fluctuates. Normal baseline is about 120 to 160 beats per minute. A tachycardic fetal heart rate would be considered if the heart rate is consistently over 180 beats per minute. The most common cause of this is maternal fever. Bradycardia is when the fetal heart rate is less than 100 beats per minute, and the number 1 cause of this is fetal asphyxia, which puts the fetus at risk of death. The next thing we're going to look at is the variability of heart rate. This is how the heart rate changes from beat to beat, and this should be about 5 to 10 beats per minute. We should see a change in that heart rate. Accelerations. If the heart rate accelerates, it's a good sign. It means the fetus is responding positively to contractions. And if there's decelerations, these can signal that there's a life-threatening event. However, it could also be harmless. You need to take a look and pay attention to what you're looking for. In the picture there to your right, it's showing a healthy acceleration. So if you start on the left-hand side of your picture, looking to the right, you see there's a nice baseline of heart rate. You see that heart rate is wiggling back and forth. That's the variability. And then it points out there where there's a healthy acceleration. The kind of green grayed out area is showing the 120 to 160 beats per minute range, and so that this fetus's heart rate is right in that range. Now what we're not seeing very distinctly in this picture is a contraction occurring with these fetal heart rates, and we're going to take a look at another one where we can see the contractions. Okay, on this slide, if you'll first take a look at your picture, on the bottom portion of the picture where there are really big looking waves, those are contractions. And so the beginning of a contraction is pointed out to you with the little red arrow, and then you see the peak of a contraction, and then followed by the end of the contraction. So that's what the contractions should look like on the fetal heart rate monitor. Okay, but this slide we're actually starting to talk about the decelerations, and there's 3 different types of decelerations. Early decelerations, also called type 1, these are benign, They're caused by vasovagal response as a result of the fetal head being compressed by the contraction. So there's pressure on the fetal skull, which changes the cerebral blood flow, or the blood flow in the fetus's brain, and then this in turn stimulates the fetus's vagus nerve. So the heart rate is gradually decreased as the pressure of the contraction intensifies, and the deceleration gradually resolves as the pressure resolves. So you can look in the picture. On the top portion of the picture, it's showing the onset of the deceleration. So you see the heart rate start to drop. You see the lowest point of the deceleration matches with the peak of the contraction. And then the recovery of the deceleration matches the recovery of the contraction. So again, early or type 1 is normal. It's a vasovagal response, and it's nothing to be concerned about. Okay, our second type of deceleration is late decelerations, also called type 2. And there's two possibilities for this type of deceleration. It can be a reflex, and those are the ones which occur in the presence of normal fetal heart rate variability. It's thought to be due to vagal stimulation by the chemoreceptors in the head in response to low oxygen tension. However, it can also be a non-reflex, and this occurs in association with diminished or absent fetal heart rate variability, and this is due to uteroplacental insufficiency. So regardless of what it is, this type of deceleration, when it is found, it could be fetal compromise, and it needs further evaluation for delivery. We might need to speed up the delivery process to protect the fetus. Our last type of deceleration is variable, or type 3, and this is characterized by a sudden, abrupt drop in the fetal heart tones, along with usually a similarly abrupt return to baseline. The classic mechanism described as the cause of variable decelerations is umbilical cord compression. Initial or mild umbilical cord compression results in occlusion of the umbilical vein, which is larger than the arteries and is less rigid. This results in decreased venous return, resulting in a reflex tachycardia to maintain cardiac output. So if you look in the picture to your right there, you see the baseline heart rate. As the contraction reaches its peak, you see the heart rate drop drastically and quickly, and after the contraction is over, you see the heart rate return to its baseline. Now, these are considered to be severe when the fetal heart rate drops to less than 60 beats per minute for 60 seconds or longer and are slower to recover. So either way, these are a little bit more dangerous, because if there isn't blood flow getting to the fetus, then it can go into fetal distress. Fetal scalp pH is implemented only when the fetal heart rate monitor indicates possible fetus asphyxia. No variability present, or there's late decelerations, are both indications to do fetal scalp pH. Asphyxia is identified because there's a lack of CO2 removed, which causes acidosis of the blood. Hypoxia causes lactic acid to increase, causing acidosis of the blood. Now, asphyxia is a normal part of the birthing process for the fetus. Normally, the pH is going to drop to slightly greater than 7.25. However, if it's becoming more severe asphyxia than normal, then the pH would be between 7.2 to 7.24, and severe asphyxia is going to be anything less than 7.2. So as the acidity recognized by the fetal scalp pH becomes more acidic, then there needs to be a more rushed delivery process, because those are dangerous asphyxiating levels for the fetus. Again, there is some normal asphyxiation as part of the birthing process, but when it becomes abnormal or more severe, that's when we need to intervene.